Joe?
We have our first email question, which I will pose to Dr. Anderson with subsequent comment by Dr. Olds. How can you tell if the cancer has spread before surgery, and if it has spread, would the patient still be a candidate?
The previous slide outlining various diagnostic tests would contain most of the means of determining if the prostate cancer has spread prior to deciding upon what therapy would be best for the patient. Digital rectal exam can give a fairly good idea of local spread. Prostate ultrasound can give some information both through the images and also by allowing directed biopsies of the seminal vesicles to determine involvement of these structures. Bone scan can help with determining bone involvement, as can a chest x-ray assess the chest. These would be the two most common sites of extraprostatic disease aside from the lymph nodes. Lymph node involvement is typically microscopic and below the threshold of detection of imaging studies such as CT scan and MRI. Prostate scan, which is a nuclear medicine study, can aid in determining lymph node involvement, but has some variability with regard to sensitivity and specificity. The surest way to assess lymph node involvement would be lymph node dissection and pathologic evaluation of the specimen, which is not always practical. Regarding suitability for surgery, in general, patients should have organ-confined resectable disease to be considered for radical prostatectomy. An exception to this would be patients who have microscopic lymph node involvement without high-grade, Gleason grade 4 or 5 component in their prostate biopsy. Patients have been shown to benefit from a combination of radical prostatectomy and hormone therapy in this case, as opposed to either therapy alone. There are some advocates of utilizing radical prostatectomy in conjunction with other multimodal therapy that we'll cover subsequently in patients who do have locally advanced but still resectable prostate cancer, or metastatic disease and a resectable prostate cancer, but at this time that is not the standard of care.
Dr. Olds, do you have any further comments?
I think the only follow-on I'd have to that is occasionally patients have a pre-op evaluation that shows no evidence of spread, and we find microscopic spread after successful surgery and consider adjuvant treatments in the aftermath of that. So sometimes the final pathology report contributes to detecting spread of disease.
Certainly. Now, Dr. Olds will continue the discussion with the role of radiation therapy in the treatment of prostate cancer.
The focus of this webcast is prostatectomy with an emphasis on robotic laparoscopic prostatectomy, but I was asked to comment on how that meshes with radiation therapy options, largely for two groups of patients. There's a group of patients that are very suitable for surgery, but they personally elect not to have it for personal reasons. There's also a group of patients that would be technically suitable for surgery who have coincident medical conditions where the surgery risks for that individual are considered unacceptably high. And the slide basically shows 5 different scenarios in 3 broad groups where radiation has options that can complement or add to prostatectomy. The first 2, SEEDS as monotherapy, which means only treatment, and IMRT as monotherapy, match with patients that have early stage, favorable prognosis prostate cancer, would be perfect for prostatectomy, but perhaps elect not to have it or have medical conditions that prevent it. In each of these methods of treatment, we really focus the radiation on the tissue the surgeon would remove if the patient had a prostatectomy. The SEEDS accomplish that treatment by putting radioactive seeds inside the prostate, treating it from the inside out. And the IMRT is an external beam-directed technique that accomplishes the same task. And conceptually, as you see some of the images of the prostatic surgery, you can imagine dose clouds of radiation replacing that surgery by treating essentially just the tissue the surgeon would remove with a very tight margin. Triple therapy is a second group, and that applies to intermediate risk prostate cancer patients. These are men that would typically have a T2 primary tumor, PSAs between 10 and 20, possibly a Gleason score of 7. And these gentlemen are suitable for prostatectomy, but there's at least a 15% risk that they'd have microscopic extension outside the gland. And in that case, if they're declining surgery or medically unsuitable for surgery, we perform a series of treatments involving hormone manipulation followed by external beam to get a good treatment boundary around the gland and a seed implant to follow. Finally, there are two situations that involve prostatectomy. One is immediate post-operative adjuvant therapy. That's the situation I alluded to with Dr. Menon just a moment ago. The patient appears to have early-stage organ-confined disease. They have the appropriate surgery, and on the final pathology specimen, we see microscopic extensions outside the capsule, possibly involvement of the seminal vesicle, possibly a positive surgical margin. And those can happen because each of those is microscopic and not detectable during the surgery. In that case, we typically advise post-operative external beam radiation to eliminate those nests of cancer cells. The final group I just mentioned briefly for completeness. Occasionally a person appears to have organ-confined disease. The operation goes perfectly well, they heal well, and they have an interval of follow-up with serial PSAs that may run for several years before it begins to creep up again, indicating possible metastatic disease out in bone, possibly local recurrence in the prostatic fossa. Those patients undergo a series of tests, and if we don't find any evidence of distant spread, then they have radiation to the prostatic fossa at a later date. In terms of our program here, when we do seeds alone, we need a gland size less than 60 grams, a PSA less than 10, a Gleason score less than or equal to 6, and no history of any transurethral surgery. This is the group that is textbook perfect for prostatectomy, but again, as I mentioned, some patients decline and other patients are medically unsuitable. For intensity modulated radiation, there's multiple different methods of delivering this kind of treatment. They're all external beam treatments of various types. I'm doing that here for approximately 6 years, and we generally use a multi-leaf collimator step and shoot approach, typically with 5 different beam angles, sometimes 7, sometimes as many as 9, and typically with about 85 different treatment segments. And what that means in practical terms is the beam is repeated approximately 85 times with multiple boundary configurations, again, to create a dose cloud of radiation that very closely surrounds the gland as the surgeon would remove it with a tight margin. And those patients are set up with daily ultrasound. Ours is mostly a rural practice. Patients that have a choice between both of these generally opt for seeds because it's more convenient for them. The IMRT takes about 9 weeks to complete on the calendar. Patients getting triple therapy are that intermediate group with PSAs of 7, PSAs of between 10 and 20, Gleason scores of 7. They have a high enough risk of extracapsular extension that we begin their treatment with 2 months of hormones, usually with a medicine called Zoladex. Follow that with external beam radiation for 5 weeks and then seed implants as a boost.